Actually really excited to talk about clinical assessments and structure today. We've been doing a lot of stuff about statistics and math, and this is the stuff that you're going to be doing now if you haven't already. And definitely the stuff that you will be doing immediately in the field if you pursue any kind of career in the mental health counseling field. In my opinion, what is most important to take away from this course is understanding what different clinical assessments are out there, how they can be utilized, how they can be interpreted, how to conduct a psychosocial assessment, which is the type that you will be doing most frequently, how to incorporate different kinds of assessment tools like screenings into those comprehensive assessments, and then how to be at least familiar enough with the basic concepts of interpreting assessments so that if you were ever in a situation where you are trying to select an assessment tool to utilize, that you would be able to make that selection with some confidence. Now, are you going to need to analyze the outcomes of multiple people's data? Probably not. So today, let's talk about the initial clinical assessment. This is by far one of my favorite elements of mental health counseling and working with clients. I also teach an education program for employees that are working from different agencies and working towards becoming certified alcohol and drug counselors. And I stumbled upon this quote while working with that group of individuals just recently. And this has become my new favorite quote, and I feel like it applies so much to the world of assessment and treatment planning in clinical mental health counseling. A little knowledge that acts is worth infinitely more than much knowledge that is idle. There are going to be a lot of times when we're working with clients and we do not get all of the information. We can do our very best to get as much information as is possible and as is relevant to the work we are doing with our clients. But for various different reasons, we're not always going to have the whole picture. Now, as assessors, it is our responsibility to get as much of the picture as possible. But what's more important than that, as counselors, is that we then take that information and do something with it. And what we want to do is provide individualized, person-centered care. So let's talk about the initial interview. This is usually your first interaction with a new client. And a lot of agencies will require that you conduct what they refer to as a provisional assessment. And that's kind of your initial assessment based on the information that you receive from a client at first contact. And then later on, the agency will require that you follow up with a comprehensive assessment that provides more information now that you've had some time to work with the client and gather more detail. So that's one approach. At other agencies, you will find that the initial interview is the extent of the comprehensive assessment that you are conducting. You may have opportunities later down the road in your treatment to update the assessment as you receive new information or the client's presenting issues significantly change, but otherwise, you're confronted with this new person and you're required to complete a comprehensive assessment of one kind or another for this client. Best practice, and what I require at the agency I work at, is that individuals complete the assessment within 24 hours. Close, sign it, done. That's a lot of information to collect at that first interaction. And that can put a lot of stress on the counselor, especially as a new counselor. And it can also be off-putting to the client to sit down and their first interaction is such a question and answer format that can be a bit much. There are some key components that you're always going to collect. How you collect and document that information may vary depending on what kinds of specialized forms you're supposed to fill out. There's Agencies have more often than not electronic health records, and they have built-in assessments, and you have to go in and fill in the blanks. That's really, really common. If you are in private practice and you are conducting an interview and you're not using an electronic health record system, you are still going to want to track in your own template some of this basic core information because it's relevant. And that's the demographics: age, date of birth, sex, gender identity and preferred pronouns, occupation, marital status, those core bits of data that we are all so used to filling out on new patient forms when we go to a new dentist or doctor or whoever. It's always the same, right? That basic demographic information. Then you collect client background information. The kind of background information you obtain may vary depending on the reason for this client being referred to you for treatment. It will also depend on what kind of service you plan on delivering for this client. For example, if I'm meeting with a client to address some significant mental health symptoms, a lot of the background information I'm interested in is their family history, their developmental history, and the history of their mental health symptoms and how that has progressed and what that has looked like over time. So there's background information that's specific to the client's presenting issue. Another example is in the drug and alcohol counseling world. We conduct ASAM assessments, and a large component of the ASAM assessment is finding out about a client's substance use history and going into a lot of detail about what that history has looked like, including withdrawal symptoms and all sorts of things. We also want to know about the person's health and medical history. And this is particularly important because our physical health really does affect our mental health and plays an important role in a client's treatment, even if it's not directly. When I worked in secure psychiatric residential treatment for youth and adolescents, I worked with a significant number of young people with a history of trauma and a variety of cognitive challenges, a variety of psychotic symptoms and anxiety symptoms. One component of the assessment process that was really important when working with this population in particular was to find out if they had a history of TBIs or traumatic brain injuries, to find out if they had had any serious prolonged illnesses, to find out if they had had any significant surgeries or injuries or ailments. Because that information, as you can imagine, really influences a person's development, their current mental health and learning abilities. It also gives us an idea of this person as a whole. It gives us the whole picture of this client. We also really want to know the client's presenting concerns. What brings them here today? What brought them to treatment? Why were they referred to us? Why did they refer themselves? What is this person expecting to get out of treatment? If the person isn't sure what they're expecting to get out of treatment, what prompted them to make the phone call or the appointment or to walk through that door? What do they want to see change in their life or improve? What goal do they want to achieve? This is a great opportunity to also develop trust and rapport with our client. So if I'm sitting down with a new person, I may or may not have had many interactions with them previously. Now I'm conducting this assessment with them. After making sure that they feel comfortable with the environment that they're in and are aware of the confidentiality agreement that we share between us, as well as the limits to that confidentiality, I want to explore with this client what's going on for them and what brought them through the door. Immediately opening it up to the client and asking them for that information automatically reinforces to the client that they are in control of their treatment and that this is a service that is for them and is intended to be done with them and not to them. It's supposed to be a participatory process. So we want the client from the get-go to identify for us what brings them through the door. Do they have an idea of what their goal is? And by the way, the more specific that goal is that you're able to identify in the initial assessment, you can then use that goal later when you're developing the treatment plan with them. So we want to know, why are they here? Tell me more information about the specific problem that you're presenting with. When I was working with children and adolescents and young adults, a lot of times were referred to us because of some significant behavioral problems. At this particular agency, it was a secure psychiatric facility. It was considered one step down from the hospital. So basically, it was functioning as kind of a combination subacute care as well as PRTS. And basically what that means is that these were individuals who were considered stable enough to not need to be in a hospital anymore, but were not nearly stable enough or safe enough to be in a regular home and school and community environment. So a lot of times these individuals were struggling with very much external behaviors, outbursts, aggression, violence, as well as in self-harming behaviors, suicidal ideation, suicide attempts. More often than not, there was some sort of precipitating factor that resulted in that person being admitted to the hospital and then somewhat stabilized and then being sent to us. I wanted to know right away what led up to them going to the hospital. What was the event that resulted in them being hospitalized? Or if they weren't hospitalized and referred directly to us, what was going on that escalated to a point where now they need our level of care? So I would want to know about the details of that event or series of events or general theme. And then I want to know more information about the history relating to that. So in the instance of a kiddo struggling with significant violent outbursts, I want to know how old they were when these violent outbursts occurred. I want to know how those violent outbursts progressed over time in duration and severity and frequency. Tell me about how often you would have a big temper tantrum when you were little versus when you were older. Tell me about what would set you off when you were little. Tell me about what sets you off now. At what point did you start to become physically violent? At what point were you punching walls or hurting yourself? These are all questions that I want to know, and I want to assess the intensity of those problems. So how disruptive is this concern in the person's current life? One thing that I do is conduct mental health evaluations on individuals who are receiving drug and alcohol treatment services and determine what else is going on with their mental health, trying to drill down and clarify a mental health diagnosis, recommendations, really identifying how we can address both the substance use disorder and the additional mental health disorders that are clearly impacting this client and that need to be addressed concurrently in order for this client to get better. A lot of time, symptoms involve significant anxiety, maybe related to a history of trauma. And again, I want to know the intensity of that. When I'm asking these kinds of questions, though, I try to do so in a fairly conversational manner. We'll end up developing our own style as clinicians. We also learn how to adjust and adapt our style based on the setting and the type of person we're working with. When I'm conducting an assessment in particular, I am quite conversational. What's key is making sure that you are developing rapport and trust with this client while also collecting the information you need. So I need to jump around when I'm conducting an assessment and kind of go with the flow depending on what the client is talking about now. A lot of times in agencies, you will be given some sort of an assessment that you're supposed to complete, maybe an assessment tool, and it's in a certain order. And so the tendency for a lot of new clinicians is to simply go down the list in order and collect all of that information. But I strongly discourage people from looking at their computer screen when conducting an assessment. I understand that ASAM assessments, for example, have really structured questions and bits of information that you're supposed to fill out, and clicking on certain buttons, make new buttons appear and things like that. In the agency I work at, I created what I call an assessment worksheet. The clinicians can take notes on this physical piece of paper, scribbling all over it, taking notes, filling in the blanks while talking to the client. And then after the session, they can refer to their notes and plug in that information into the assessment. And I designed that worksheet to match the assessment that I built in the electronic health record system so that it's really easy to kind of move that information into the computer. That is one method. Again, everybody has their own methods. When I sit down with a client, because I like to jump around topic to topic so much, I keep in the back of my head certain topics that I know I'm going to need to address. Just have a blank notepad in front of me and literally scribble all over it, write really weird notes that I sometimes have a hard time deciphering afterward. But I follow the client and I have to guide it a little bit to keep us moving forward. And we're usually limited to a chunk of time. And so we have a lot to cover and I want to make sure I get the information I need, but I'm also going to let the conversation flow in a way that allows the client to feel like they have some control in the situation. So for example, maybe the client and I are talking about the history of their mental health symptoms, and that leads them to talking about how it has impacted their relationship with their mom. So now that's a perfect segue into talking about their mom and their family and say, tell me about your mom. Does your mom have any mental health symptoms herself? Or do you know if your mom ever was in counseling of any kind? What's your relationship with your mom like? Did you live with her? Who did you live with at home? And then maybe in that conversation, they mentioned to me about how their brother is a mechanic. And so then I use that to immediately swoop into, oh, that's an interesting job. What do you do, by the way? What is your job, right? So the fluidity of an assessment certainly comes with time and practice. But I find that using that approach allows me to get a lot of information really quickly and to, at the same time, establish a really good rapport with the client. And the more comfortable they are during that conversation, the more open they're going to become. It also makes it easier to ask the hard questions, to ask questions that start to feel a little maybe uncomfortable to ask, like details of a history of trauma or suicidal ideation or current risk of violence towards others. Those questions can be a little nerve-wracking, especially for a newer counselor to ask. But when you are developing such a good relationship with the client in the moment and demonstrating that you are trustworthy and accessible, those questions really do become much easier to ask. And so when I'm having this fluid conversation with clients and getting the information that I need from them, I'm also going to be asking them to clarify for me the intensity of certain things. So for example, I may be talking to them about their anxiety, and they tell me that they struggle with anxiety. I will ask them what that looks like, what kind of symptoms they have. Does it affect their sleep? Does it affect their physical activities? Does it affect their social life? And then I will also ask things like, tell me this, on a scale of 1 to 10, 1 low, 10 extreme or severe, what is the worst level of anxiety that you achieve on a daily basis? Or tell me on a scale of 1 to 10, what is your anxiety level right now? What is it usually on a given day? When was the last time it was a 10? Has it ever been a 10? When was the last time that you remember it being like a 1 or a 2? And what did that feel like? So that's a good way to get some intensity, right? Is to determine what the client's own rating of the severity is. You can also assess a problem's intensity by utilizing different diagnostic and assessment tools as part of your assessment process, like implementing the PHQ-9 or the GAD-7 or the PSS screening. These are all methods to collect more information that really specifies the intensity of the person's issues. We want to know. We want to know if this person has ever received counseling before, whether they've ever received psychiatric services before. Have they ever been on a medication? Have they found that medication to be helpful or unhelpful? Were there adverse reactions to the medication? A lot of young people that I used to work with would experience exacerbated symptoms when on certain mood stabilizers. We also want to know what is feasible for the client right now. A lot of clients feel very limited in their ability to embrace change And depending on the setting that you are working with this client in, whether it's an outpatient community mental health center, whether it's in private practice, whether it's in a residential treatment facility or a psychiatric hospital or at a school, everybody has something else going on in their life. And we want to know what this client really feels like they can do and what they feel like they need to do to get better and to find a sense of hope and stability and happiness. And we don't want to completely overwhelm the client or put a bunch of expectations or plans or goals on them that is based on our own agenda or based on what we think the client ought to do or want. A client is not going to come back routinely and engage in treatment services if those treatment services are completely ignoring or neglecting the client's personal preferences. My method, I guess, would fit most under the concept of a semi-structured interview. There's groups of information that I'm collecting, but I'm also flowing with the conversation and keeping it really person-centered and really very certain focuses depending on what kind of emerges during that assessment. Our structured interviews that are really structured, those are often in context of assessment tools that involve scoring and calculating the outcomes. For example, the PSS or the EDI. Those are assessment tools that require a specific order, calculating the scores in the end, and making sure that I am structured with my approach. Structured interviews are very much more impromptu. These are the interviews that we conduct when we're really adapting to the client's needs and meeting them where they're at. This is most common when working with younger clients. Your approach is probably going to be more on the side of unstructured. A really clear example of that is when clinicians working with young children are conducting an assessment or an evaluation. They may incorporate quite a bit of play therapy and role play to understand what's going on for the client and to identify how the kiddo is responding to them in different ways. Perhaps the most unstructured interview I've ever conducted was when I was working in the secure res facility and a kiddo came to intake and immediately ran away. And so we had to chase after him. And I caught up with him and he was walking on a street and he was crying and was very upset, understandably so. And so while walking together back to the facility, I started asking him questions. And we were also looking at rocks and plants and commenting on cars. And he was showing me a special handshake. We were going through all these different kinds of things while still gathering really useful information. So that would be an example of a time where you kind of adapt to the situation and collect what information you can. Aside from when you are asking a question or trying to get a really concrete bit of information, when we are talking to clients, we want to use those core helping skills that you first started learning at the start of this program and that you are probably relying on very heavily right now in your internships. We use those minimal encouragements. We shouldn't be the ones talking the whole time. It's an assessment. The client is telling us pretty much their life story. That requires the client to do most of the talking. Now, there are clients that are less talkative, that do require more prompts and questions and encouragement. But in general, when a client is talking, we should be using those minimal encouragements. The yeahs, the sures, the rights. With me, I think I use a lot of yeahs and ahas. I also use my facial expressions quite a lot and my body positioning when I'm indicating to a client that I am confused or surprised or concerned. There's a lot of minimal encouragements that don't even require words at all. We want to be able to get more information, more detail when we can. And so that requires those open-ended questions or invitations for the client to give you a little bit more detail. Sometimes I will ask a client to clarify what they mean when they say a specific word. So if a young client tells me that school is freaking horrible, I'll ask them what freaking horrible looks like. And that not only then validates the client and what they're saying and indicates that I'm accepting and am open to what they're saying, but then it also prompts them to tell me more information. So we use those open questions. We try to avoid the closed questions, but of course, during an initial assessment, there are those core questions that we have to ask. We have to ask, are you having thoughts of suicide or hurting yourself right now? Those are more of the yes or no questions. I want to follow those up with the open questions. And we want to invite the client to tell us more about what was going on. I love the what was going on, or what happened next, or tell me what that looks like. We're asking the client to be more specific sometimes so we understand what the client's actually saying. And there are times when we might want the client to repeat themselves or to explain a little bit more of what they mean. And it often results in the client elaborating and giving you even more information or setting off a light bulb in your head that, oh, there's this other thing that's going on for them too that I should ask them about next. For example, it is not uncommon for me to hear from a client that they experience really angry, negative auditory hallucinations. And then upon further discussion, it turns out that that voice is their significant other, an ex-partner, a parent, and this prompts me to start asking them more about their history of trauma. It then results in me asking them about other symptoms associated with PTSD, like dissociation and sleep disturbances and nightmares and flashbacks. Suddenly, I'm getting all this information that I hadn't even started to gather yet because the client gave me a little bit of information that could have gone in a few different directions, right? We also want to make sure that we understand what the client means when they say something, because that can vary. There are definitely cultural elements to that as well, where different cultures may have a different interpretation of certain words or phrases and what that means to them versus what it means to someone else. It's going to vary. And we want to make sure that we're on the same page with the client. Because unless we know what the client is actually presenting with, we're guessing, which is unfair to them. When interviewing children, it's really important when able to establishing rapport with the family as well as the client to some extent. If the legal guardian, whether that's DHS or an actual biological parent or a foster parent or another important figure in that client's life, if there is any involvement that you can get information from separately at times from your interactions with the kid. If there may be times when you have an assessment with the parent present, then you're kind of balancing asking questions between the two and making sure that you're getting information that is accurate to the kid. But we want to make sure that we're approachable to the kid and that we're asking questions that make sense to them, that aren't using a bunch of jargon or terms that they don't necessarily know the meaning of. A really young kid might not know what you mean if you ask them if they ever struggle with insomnia. But if you ask them if they have a hard time sleeping, they may be able to tell you. It's also really important when working with young people to use an extra amount of time to explain what our role is and why we're there, and then defining the limits of our confidentiality with that young person. One of my very favorite intakes I ever conducted with a young person involved us making shadow puppet while sitting in a conference room. He had just come out of the hospital. I think he was like 7 years old, and he was really distracted, and he started playing with shadow puppets, as in he was, moving his hand in front of this wall, and he said that he was creating a monkey. So I joined him, and I made a moose with my hands on the wall, and my moose started asking the monkey questions about this client. And the majority of our assessment was a conversation between the monkey and the moose. It went quite well. At some point, he started to direct questions and answers to me instead of to the shadow puppet. And by the end of the assessment, we were just having a much more regular conversation. But we had also, in the meantime, developed quite a good relationship. And I discovered in that interaction with him that this is a really playful and imaginative kid. We ended up incorporating that quite a lot in our work together. Other strategies and tools you may utilize are standardized or informal checklists or rating scales, Likert scales. So asking somebody to rate something on a scale of like 0 to 10 or any variation. Those are all ways that you can get more information. It's also really important to utilize those kinds of tools when you are trying to clarify a diagnosis or drill down on a diagnosis or rule out a diagnosis. That's a time that you may very much want to incorporate the PSS or the GAD-7 or the PHQ-9. And I keep repeating those ones because, frankly, they are the screening tools that I most commonly see utilized. Also, the Columbia Suicide Rating Scale. And those tools are really useful in further informing our picture of this client. Another core component is to conduct a mental status exam. So this is a way to cover the core elements of a client's level of functioning and self-presentation. And generally, this is incorporated as part of that initial session. There are often suicide risk assessments that also involve the mental status exam, but otherwise, you will definitely encounter mental status exams most frequently in the context of that initial assessment. The mental status exam usually addresses things like how the client physically is appearing and presenting themselves to you, both in attire and hygiene, and also in like their movement and activity. We're noticing their mood and affect and noticing if there are any incongruencies between how they are presenting themselves facially versus verbally. So if a person appears with very flat affect, but is telling me that they're really upset, that's noteworthy. We make notes of things like speech and language that may indicate that this person has a processing disorder or maybe has some difficulties expressing themselves effectively. We want to know about their thought process, content, and perception. This really involves drilling down on the presence of delusions or hallucinations, any paranoid thinking. And we also want to learn about this person's cognition and their insight and judgment. So these next couple of screens are the mental status exam that I built into one of our assessment tools at the agency I work at. So I literally just took screenshots of that form so you could see what it looks like. This is just one example. So you will find that a lot of agencies utilize like multiple choice basically, and then there's like a comments box at the end for you to provide more information or to clarify what you meant on something. There will be others where it's just a bunch of blank text boxes or drop-down menu options, or you aren't using a form at all. And so instead you are just on your own kind of going through these different topics and addressing it. You see here that we're asking about their mood and their attention, their perception, their thoughts. This is where we can get an idea of if this person is particularly grounded in reality. Here we're indicating whether the person is presenting as cooperative versus agitated or withdrawn. We may notice some bizarre behaviors, the person responding to internal stimuli, or you may find with some individuals experiencing psychosis that they will be dressing inappropriate to the weather and may even be adding on layers while talking to you in the assessment. I know that's weirdly specific, but that is something I've encountered more than once. That's noteworthy. So I would include that in the mental status exam. We also note things like eye contact, the level of insight that the person demonstrates, and the level of judgment that the person demonstrates. And again, this is based on our observations and what the client is telling us. So now we come to one of my next favorite topics, which is the golden thread. And so behold the spool of golden thread. You may or may not have heard much about the concept of the golden thread, but I always like to introduce it sooner than later in the clinical process, because it is so important both in the documentation world,
but also in service delivery. So the golden thread is not literally a golden spool of thread, although I do like to pretend that it is. It's the idea that there is a connectivity between each aspect or phase of the client's treatment. So the golden thread should flow from the assessment to the treatment plan. That means that all of the needs and risk factors and concerns and goals that I identify in that assessment should then be represented and addressed in one way or another in the treatment plan. And that may vary depending on what kind of a treatment plan I've developed. It may vary on what kind of a form your agency is having you complete the treatment plan inside of. But at the end of the day, your approach to treatment and your plan for treatment should accurately reflect and connect back to what you learned about the client in the assessment. What is so exciting about the assessment, it's an opportunity for you to learn about a person. People are interesting. The assessment is fun because you get to identify who this person is and identify their needs and their risks. You establish that medical necessity that indicates that, yes, this person needs treatment right now. And then you get to use that information to inform what you're going to do with that client. At the end of the day, a treatment plan cannot be developed prior to conducting and completing an assessment, because you will not know what to treat or what to prioritize treating until you've gathered the information that's represented in an assessment. Then you have the golden thread that flows from treatment planning to service delivery. So in your service delivery, you are ultimately addressing the needs and concerns and risk factors that were initially identified in the assessment.